Today we're going to be talking about abnormalities of the right ventricle, and there are a number of these. Hypoplasia, of course, is one of the problems that we see with either ventricle, and probably the most common defect in which we see hypoplasia of the right ventricle is pulmonary atresia with intact septum or severe pulmonary valvular stenosis. These are both associated often with some hypoplasia of the right ventricle, PAIVS, often quite marked hypoplasia. And then we can see unbalanced AV canal defects. Most of the time we think of them favoring the right ventricle, but occasionally we see AV canal defects where the right ventricle is small and it's an unbalanced defect favoring the left ventricle. Occasionally in transposition, either transposition with a ventricular septal defect, coarctation, this kind of complex can be associated with a small right ventricle, small tricuspid valve, or even transposition with intact septum can have a smallish right ventricle associated with it. And as we saw when we talked about atrial abnormalities, left-sided juxtaposition of the atrial appendages is often associated with right ventricular hypoplasia, tricuspid valve hypoplasia, even tricuspid atresia. And occasionally we can see patients with corrected transposition, congenitally physiologically corrected SLL transposition with a small right ventricle. So the history that you would usually see is some cyanosis, because if the right ventricle is small, that means there's either right to left shunting, if it's the usual kind of arrangement of the heart across the atrial septum, or there may be more mixing lesion if it's, say, corrected transposition or something. And the exam may not have any specific findings except for desaturation. The electrocardiogram, you would see smaller right ventricular forces than you might expect for whatever the defect is. In the chest x-ray, there's usually no specific finding for that. For pulmonary atresia intact septum, you can see very small right ventricles. Here's an example of a really tiny right ventricle. There you can see the pulmonary valve. There's just flow from the ductus coming retrograde into the PA. There's no antigrade flow in this case. Here's another pulmonary atresia intact septum, but with a much larger right ventricle. Here you can see this is almost normal size. It's only mildly hypoplastic. So you can see quite a bit of variation in this. Over here in the left now you can see there's some tricuspid inflow. And of course this is a ductus dependent lesion. You can see a big duct here that'll have left to right flow in it. On the other side, you can see right to left atrial flow. That's why these babies are blue. Even though this is a good size tricuspid valve, good size right ventricle, there is pulmonary atresia. So all of the flow really has to go across the atrial septum. And there's often tricuspid regurgitation associated with this. There you can see the plate-like pulmonary valve, pulmonary atresia. We'll look at this in more detail once we talk about pulmonary atresia intact septum. And then an unbalanced AV canal. We looked at this when we talked about AV canal defects, but here you can see there's a big left ventricle here. Almost all of this AV valve is over the left ventricle, and the right ventricle is quite small with just a tiny bit of the right side of this common AV valve sitting above the right ventricle. And there's some accessory AV valve tissue that you can see there that's blowing up into the right ventricular outflow tract. Transposition with a ventricular septal defect and some right ventricular hypoplasia here. Here you see the branching pulmonary artery aligned with the left ventricle here, pulmonary to mitral fibrous continuity over there. And here you see a small tricuspid valve, smaller than the mitral valve, a small right ventricle in this patient. And you can see there is a ventricular septal defect here. There's the PA and the aorta coming from this smaller right ventricle. You see it's quite a bit smaller than the left ventricle in this case. These patients can usually have an arterial switch operation, but it's important to keep in mind that they often have pleural pericardial drainage, much like our Fontan patients after surgery. Here you can see a the same patient, and you can see the difference in size of the tricuspid valve and mitral valve. Usually the tricuspid valve is about 25% or so bigger than the mitral valve. Here you can see it's the other way around. So right ventricular and tricuspid valve hypoplasia. And the tricuspid valve goes along, the size of it goes along with the size of the right ventricle. So measuring the tricuspid annulus often tips you off to the presence of right ventricular hypoplasia. Here's another example. You can see the atrial septum bowing from right to left, and there's the right atrial appendage going across to the left side. You can see it right there where the hand is on there. And here you see a small tricuspid valve, small right ventricle, ventricular septal defect. And you see the septal leaflet of the tricuspid valve, some accessory tissue there is bulging through the ventricular septal defect. But here you can see how small this right ventricle is supporting the aorta. And there you see the accessory tissue from the tricuspid valve blowing across into the left ventricle. So this is left-sided juxtaposition, just to show you that again. Here's the right atrium, and there's the appendage going across to the left side. You can see how it does that. Goes just behind the pulmonary artery there and ends up on the left side with the left atrial appendage just below it. And in corrected transposition, sometimes we see a small right ventricle. There's a big VSD here. Here's the pulmonary outflow. There's the aorta. This is all left ventricle down here. You can see the right ventricle is relatively small up there. And in fact, there's shunting from LV to RV in this case across the ventricular septal defect because the RV is relatively small. Here you see in short axis. LV big down here is smaller, RV in the back. And this can, blend into double inlet left ventricle with the straddling of one of the AV valves, usually the tricuspid valve. And so you can end up with a very small outlet chamber here and a big left ventricular chamber on the other side. If you were at conference this morning, you heard about septation of a patient with double inlet left ventricle. This is being resurrected here. This was treatment that was done some years ago, maybe 30 years ago, 25 years ago. The Mayo Clinic was a big proponent of that. And now it looks like Ram and our surgeons here have resurrected this idea and are starting to do, he said they'd done, I think he said 4 or 5 cases, and they had a couple that had gone to completion of septation of a double inlet left ventricle. So it'll be very interesting to see what happens with that, to see if the results of that turn out to be better than the results of Fontan operation. We certainly hope so. So the treatment for right ventricular hypoplasia, if possible, obviously a 2 ventricle repair is what we would want if the RV and tricuspid valve are adequate for usually the pulmonary circulation, or sometimes a so-called 1.5, where you do a bidirectional Glenn in addition to using the right ventricle to supply mostly the left pulmonary artery flow. Otherwise, if the tricuspid and RV are really quite small, then probably a Fontan palliation is most likely what we would do. Another abnormality that we see of the right ventricle is what's been called double chamber right ventricle, or right ventricular muscle bundles. You may hear that name for it as well. And what we mean by that is obstruction at the inlet into the infundibulum, or what's called the proximal os infundibuli, the mouth of the infundibulum. It's the junction between the right ventricular body and the outflow. It's usually where the septal band and the parietal band and moderator band form a ring between the inflow part where the tricuspid valve attaches below and the outflow part that supports the pulmonary valve above. And we think this is at least in part due to basal displacement of the moderator band, that it takes off from the septum a little more basally than normal, and that the parietal band is often quite broad in these patients. And the two of these things encroach on this junction between the inflow part of the right ventricle and the outflow part and narrow that, causing obstruction. It's a little like tetralogy. There's usually a ventricular septal defect membranous that's associated with the inflow part of the right ventricle. So as the obstruction becomes worse, these patients begin to shunt right to left, like tetralogy of Fallot. And the other thing to keep in mind is about 10% of these patients have subaortic stenosis. So if you see somebody with double chamber right ventricle, it's important to look for specifically subaortic stenosis, because it occurs in about 10% of patients. And sometimes the ventricular septal defect will have closed spontaneously by the time you see the patient, and they present with suprasystemic right ventricular pressure, right ventricular failure, big liver, and this kind of thing. But usually they present with a murmur. So there's often a history of a ventricular septal defect, and then babies might be in heart failure early on, but then get better as the obstruction worsens, because it sort of acts like pulmonary artery banding. It reduces the shunt flow. They may get a little bit blue then if the VSD doesn't close spontaneously and persists as the right ventricular outflow tract obstruction gets worse. They're usually pink, but can be cyanotic if the obstruction is quite severe. There's usually a forceful right ventricular impulse because of right ventricular hypertrophy and hypertension. The first heart sounds normal. The second heart sound may be normal. It may be hard to hear. It may close quietly because pulmonary artery pressure may be pretty low. There's usually a loud systolic ejection murmur at the left mid-sternal border, a lot like tetralogy, although the murmur is often a little lower down the sternal border than what we hear in tetralogy. There's usually no diastolic murmur because pulmonary blood flow is often limited by the obstruction. If they present late with suprasystemic RV pressure with VSD closure or VSD becoming smaller, you may see hepatomegaly, right ventricular failure. They usually have normal pulses. The left side of the heart's usually pretty normal, except for the subaortic stenosis that can occur. And we typically see right ventricular hypertrophy, right atrial enlargement on the electrocardiogram. The chest x-ray is usually pretty normal. Early on, you may see a big heart and increased flow before there's much obstruction. The obstruction seems to be progressive over the first months to year or so of life. So it may convert from being more like a big VSD with heart failure to being more like tetralogy of Fallot. And what these look like, here's just a still frame of a double chamber. You can see there's a big muscle bundle here, both on the free wall and on the septum, that the right ventricular outflow is up here, the infundibulum, and here's the inflow part down here, and that's the level of the obstruction. Now we found, this was when Pierre Wong was a fellow with us many years ago, that the distance between the takeoff of the moderator band here and the pulmonary valve is very different in patients with double chamber from patients with just a ventricular septal defect. So if you measure that distance, it's predictive of the ones who are going to develop double chamber. We looked at normals, at regular ventricular septal defects without outflow obstruction, and then patients who presented like a big VSD, but then eventually developed double chamber, and those that presented as double chamber. And you can see this distance between the takeoff of the moderator band and the most proximal part of the pulmonary valve is quite different here to here. And you can see that reflected here on the graph over here. So that's a useful measure. So here's an example of a patient like this. Here's the muscle bundles here. This is the infundibulum or outflow up here. This is the right ventricular inflow down below. And you can see that this is quite hypertrophied. But if you look up here, the infundibulum is fairly narrow, fairly thin-walled, because the pressure here is low. Here you can see the obstruction is right there. And notice how high the takeoff of the moderator band is. It's very close up here to the pulmonary valve. Here you can see another example of this. And there's a big parietal band over here going toward the free wall. There you can see the flow jet on color as it's going through. Here you can see the flow jet on this side as well going through. And from a peristernal view, it looks like this. You can see the moderator band here coming from the septum very high up, and then you see the muscle bundles. And with continuous wave Doppler, you can measure the gradient across the double chamber. Here's another example. Again, you see how hypertrophied this is. This one, I think the VSD may have closed. And you see how thin-walled the infundibulum is up above. This is low pressure. This is high pressure, and you can really see the difference in wall thickness from above to below. And you see the moderator band here, the parietal band, and you can see how this narrows the lumen at that point. And of course, you can see this with magnetic resonance. Here's another example. Here's the pulmonary valve up here. And again, you see the thick-walled right ventricle down here, thin-walled infundibulum up here, and you see the dephasing jet as flow is going across the narrowed area where the muscle bundles are, dividing the inflow from the outflow part of the right ventricle. And this one also doesn't seem to have a ventricular septal defect. This was just a reconstructions showing the muscle bundles here and sort of looking at it on FOSS, looking at it from above down, you can see how it narrows the lumen here. So the treatment for this, of course, is just resection of the muscle bundles. You just divide and remove the muscle to open it up, and if the VSD is still open, of course, VSD closure. And if there is subaortic stenosis, then resection of the subaortic stenosis if that happens to be present as well. Another abnormality that I think of as really an abnormality of the right ventricle as well as the tricuspid valve is Epstein anomaly. So it's a malformation of the tricuspid valve and right ventricle, and I think it's important to keep that in mind, that there really is a spectrum of features. One, of course, is adherence of the tricuspid valve leaflets, usually the septal leaflet, sometimes the inferior leaflet, to the underlying myocardium, or failure of delamination. And then downward displacement of the functional annulus, but also rotation, as we'll see, up toward the outflow tract. And dilation of the atrialized part of the right ventricle, the part now that's above the closure plane of the atrioventricular valve. And the leaflets of the tricuspid valve are often abnormal. They're often redundant. There are often little fenestrations in them, tethering of the free edge to the underlying myocardium so that it can't move normally and can't coapt normally, which is one of the major mechanisms of tricuspid regurgitation. And then, of course, dilatation of the right AV junction, the true tricuspid valve annulus, which then makes the tricuspid regurgitation that much worse. So here you can see sort of a cartoon showing the atrialized part of the ventricle, the displacement of the tricuspid valve, particularly the septal leaflet down the septum. The anterior leaflet often has tethering, and so the septal leaflet as well, tethering of the free edge so that they can't coapt normally. So that if you look here, that corresponds to this. This is all atrialized part of the ventricle, and this is functional right ventricle. Then if you look down farther, you can see that a cross section down here, this would all be functional right ventricle. So we often see hypoplasia of the functional part of the right ventricle. It's often smaller than normal because of the displacement of the tricuspid valve and displacement of the functional annulus of the tricuspid valve, tricuspid regurgitation, sometimes stenosis, variable outflow tract obstruction, and often a right ventricular cardiomyopathy. Often the right ventricular wall is very thin and doesn't function normally. Here you can see this on the septum. We've taken a section here across the real AV junction. This is in a patient with Epstein's. This is a normal control. Here you can see atrial myocardium. Here's the AV junction here. This is ventricular myocardium. Same thing down here. Atrium, AV junction, ventricular myocardium. This is the septal leaflet of the tricuspid valve, which continues with the central fibrous body here. You can see over here, we don't see that because of the displacement. The septal leaflet is beginning to take off way down here in the ventricle. And if we look at the underlying myocardium, you see there's a lot of fibrosis. The myocardium is not normal looking at all. It's sort of disorganized and in little muscle bundles, as opposed to being a normal myocardium that you can see here with aligned fibers all pulling in the same direction. You can see there's a lot of interstitial fibrosis, much more than what we see here in a normal myocardium. So there are abnormalities of the right ventricle as well as of the tricuspid valve. And again, you see here's a tricuspid anterior leaflet. It's a big sail-like leaflet, but you can see it's really tethered out here at its free edge. The annulus is up here, the free edge is down here, and it's quite tethered down here so that it can't move away from this area very well, can't coapt. And you can see these multiple fenestrations. Sometimes they're muscle bands that cross this as well. And this illustrates the rotation of the valve. Here we're looking, here's the right atrium back here, here's coronary sinus, this is the fossa ovalis up here, this is up into the appendage. This is where the real annulus of the valve is. You can see the annulus here. This is the normal annulus plane. The anterior leaflet takes off from the annulus, whereas the septal leaflet in this case is not only displaced down into the ventricle, but it's rotated. Instead of being like this, it's rotated around like this so that the opening now, instead of being toward the apex, which is down here, is up toward the outflow, which is up there. So we see not only displacement, but rotation of the tricuspid valve superiorly toward the outflow tract. Associated problems, of course, are arrhythmias. We know that pre-excitation, Wolff-Parkinson-White, if you will, or other pathways, accessory pathways occur in patients with Epstein's anomaly much more often than in the general population. We can see also LV non-compaction with Epstein's anomaly. It's not very common, but it's one of the things that is associated with it, and multiple VSDs. And these two often go together in some patients, a small number of patients with Epstein's anomaly. And there are a number of genes that have been implicated in Epstein anomaly, sarcomeric protein genes mostly. And this is maybe why we see cardiomyopathy associated with it. A lot of these are also associated with cardiomyopathy. So the pathophysiology here, these patients are cyanotic because there's a right to left atrial shunt because of tricuspid regurgitation, right ventricular noncompliance, often right ventricular outflow tract obstruction, often low cardiac output, particularly in neonates with severe Epstein anomaly, again, because of TR, RV functional, RV hypoplasia, or because the right ventricle can be, that and in the right atrium, particularly in neonates, can be so dilated and take up so much space in the chest that it impairs left ventricular filling. So you get an adverse ventricular interaction. And then, of course, you can have right heart failure, right ventricular failure in these patients. So the history typically is cyanosis from birth, very limited exercise ability in many of these patients. Some of them with mild disease can be actually pretty normal and not have cyanosis, not have any real abnormality, but the ones that we see are generally much more severe. They tend to have a fairly quiet precordium, even in the face of a lot of tricuspid insufficiency. Surprisingly, you would think that a volume load like this would cause an active, hyperactive precordium, but that's often not the case. I don't know why that is. There's often a quadruple rhythm, or at least a third heart sound, often a fourth heart sound, so you get this gallop sort of rhythm that you hear in Epstein's. And there's a holosystolic murmur, usually at the left lower sternal border. It may be quite low-pitched, quite faint, because the pressure difference between the right ventricle and right atrium may be pretty low. And so you just don't hear a very loud or a very high-pitched murmur. It may be a very low-pitched murmur, maybe not what you expect to hear from AV valve regurgitation. And then the electrocardiogram, right atrial enlargement, often right bundle branch block, you can see here. And part of that in this case is because of pre-excitation. You can see the P wave here. There's this upsloping here, delta wave on the QRS complex, typical of a pre-excited ventricle. Here you can see the same thing over here in precordial leads. And on chest x-ray in neonates, we can often see marked cardiac enlargement, decreased pulmonary blood flow. And the cardiac enlargement is the heart. I mean, the whole chest here is taken up by the heart. This is the chest x-ray of this neonate that died. And this is at autopsy with the chest plate removed, you can see most of this is right atrium. The AV junction is right here. This is right atrium, right atrial appendage. This is right ventricle. Right ventricular outflow would be up there. And so most of this is a huge right atrium inside here, but you can see the correspondence between the real anatomy and the chest x-ray, so-called wall-to-wall heart. And what some of these neonates with Epstein's look like is this. You can see there's a huge right atrium. It's a big eustachian valve in this case. Here's the septal leaflet that doesn't come off the septum. It's stuck. This is a big anterior leaflet, inferior leaflet down here, and we just don't see much septal leaflet because it's stuck to the septum here. You can see it's not moving away from the septum. And there you can begin to see it a little bit as we get further down into the ventricle. You begin to see a little bit of the septal leaflet, but really not very much. And you see how the anterior leaflet's tethered over here, the inferior leaflet, they're both tethered to the free wall. And here in an apical view, you can see when you get up anterior, you can see some leaflet, but here, this is all septal leaflet, all stuck down, and it doesn't come off the septum until way down into the ventricle. And there's a severe tricuspid insufficiency with a huge right atrium back here. And the pressure difference here across the tricuspid valve, this is only 25 millimeters of mercury. So the right ventricular pressure is usually fairly low. Here you can see this tethered inferior leaflet. You see how the free edge curls around because the short cords keep it attached to the free wall so that it can't coapt. And this is the septal leaflet that is not delaminated. It's often sort of a thick gelatinous kind of thing. Here's the pulmonary valve, pulmonary outflow. The valve does open there and then quickly closes because the right ventricle often doesn't generate very much force. If the ductus is still open and there's elevated pressure in the pulmonary artery, then there's not much flow across the pulmonary valve. And here you can see there's pulmonary insufficiency, in this case because of retrograde flow from the ductus. So this is another example. This is the left ventricle, left ventricular outflow tract. Here's the right ventricle. Here's the tricuspid valve here. This is the septal leaflet. And you can see that the valve is going to be opening up toward the pulmonary valve up here. This is all atrialized right ventricle down here. So the plane of opening of the valve is here. It's going to be up toward the infundibulum this way. And the pulmonary valve is up here. So this is all atrialized ventricle down here. The functional right ventricle is just this part up here where the pulmonary valve is. And you can see the valve opening up into the right ventricular outflow tract. And you see how this communicates with the right atrium down here. So this is all atrialized ventricle. If we look at this in short axis now, you can see the tricuspid valve here opening again up toward the pulmonary valve, up toward the infundibulum. See, there's the opening of the valve here. This is the anterior leaflet. Here's a little bit of septal leaflet there. And this is all opening up toward the infundibulum. This is all atrialized right ventricle down here. In this case, the left ventricle looks reasonably well filled. And I think you'll see why in just a minute. We scan back down. Again, you see the tricuspid valve is not only displaced but rotated so that it opens up into the infundibulum instead of toward the apex as it usually does. And there's flow from the ductus coming back, and this is antigrade flow across the tricuspid valve, but there's not a lot of tricuspid insufficiency here. Here you see this septal leaflet. It's quite tethered. It doesn't coapt. We're looking sort of from above now, back toward here's the pulmonary valve here. This is the functional part of the right ventricle up here. And this is the septal leaflet. This is anterior leaflet. So the opening of the valve is up like this toward the pulmonary valve. So this is all, again, atrialized ventricle. So there's a relatively small functional right ventricle in this case. And you can see, again, the non-delaminated part of the septal leaflet here. This is all atrialized ventricle. The functional right ventricle is over here under the pulmonary valve. And the pulmonary outflow tract is here. With good branch pulmonary arteries, but not much opening of this pulmonary valve. The ductus is open here. There you can see flow from the ductus back in. Most of the flow, pulmonary blood flow here, was from the ductus. And one additional case here. Here you can see, again, this is all atrialized ventricle. This is the tricuspid valve, again, opening up toward the infundibulum, up into the outflow tract. This is all atrialized right ventricle. There's a very small functional right ventricle in this patient. And in short axis, you can see here, big right atrium. Here's the tricuspid valve opening up into the infundibulum, all atrialized ventricle down here. Right to left shunting at atrial level that you can see here. And just a small antigrade flow across this tricuspid valve. This is an unusual one where there's mostly tricuspid stenosis and less tricuspid regurgitation. Here you can see there is antigrade flow across this pulmonary valve going out into the main pulmonary artery, but the functional right ventricle up here is quite small. See, here's the tricuspid valve. The closure plane is right here. This is all atrialized ventricle down here. The functional right ventricle is up here. So this is one where the tricuspid valve is actually stenotic with very little regurgitation. And of course, you can see with magnetic resonance very nicely, you see the displaced septal leaflet of the tricuspid valve, tethering of the anterior leaflet over here to the free wall. You can see this big regurgitant orifice here in the middle, and poor coaptation of the leaflets. And again, you can see this very dilated atrium and ventricle, in this case with a lot of tricuspid insufficiency. Now, you can also see tricuspid valve dysplasia, which is a little different because the septal leaflet isn't displaced in this case. It's just, the leaflets are just very abnormal, but they're not really displaced. Here you can see an anterior leaflet, an inferior leaflet, or posterior leaflet here, and they're tethered at their free edges, so they don't coapt very well. And you can see the septal leaflet's very thickened, very abnormal. In short axis, again, you see this anterior leaflet out here. Inferior leaflet's going to be down here. And here's the septal leaflet. You can see it. In this case, it's not stuck to the septum. It's tethered, but it's not non-delaminated. It actually comes out into the ventricle. And there's the septal leaflet there. You can see it moving here. When we get down to the apex and then back up toward the base, you can see the septal leaflet, anterior leaflet, inferior leaflet here. And they're all moving and not delaminated. Here you can see in this apical view how this goes all the way back to the annulus back here, but it's very tethered. So we have a big regurgitant orifice here in the middle. So this is a tricuspid valve dysplasia, but it's not really Epstein anomaly. It kind of looks like it, but it isn't. There you can see the pathology here is mostly due to leaflet tethering, and there's the regurgitant jet. This is just a 3D of a dysplastic valve showing the leaflets. Here's one of the commissures here that doesn't coapt. This is the septal leaflet over here. See the free edge out here is very tethered, and you can see this huge regurgitant orifice here in the middle. This is anterior leaflet up here, inferior leaflet down here, and septal leaflet over here. And as we tip this up a little bit, you can see how the free edge up here is just tethered, but there is delamination. The leaflet actually moves away from the septum. There you can see it better. Anyway, that's tricuspid valve dysplasia. Grading has been done based on how how much displacement there is, the size of the functional right ventricle versus the size of the atrialized right ventricle and right atrium. Um, the greater the proportion in the atrialized right ventricle and right atrium versus the functional right ventricle, the worse the symptoms usually are, and the worse in the past the prognosis was. So treatment for this, of course, is valveplasty, sometimes replacement, but with the cone procedure now, I think most of these patients get that and get a valveplasty, and the results look like they're going to be pretty good for this. And of course, pathway ablation, if that's part of it. The outcome is somewhat variable, particularly in neonates. Here, this was Dr. McElhaney when he was here. This was from a paper in 2005, where these were all neonatal Epsteins, tricuspid valve or dysplasia or neonatal Epsteins. And there were 33 prenatally diagnosed, and only 7 of those survived for more than 30 days. So prenatal diagnosis of severe Epstein's is often associated with a pretty poor prognosis. And of the 49 live-borns, only 35 of them survived for more than 30 days. And as I said, that index of the size of the atrialized right atrium and right ventricle versus the right ventricle, functional right ventricle, was predictive. If the right atrium, right ventricle were greater than the size of the functional ventricle, then this was had a fairly poor prognosis. And the other factor or the other indicator was absence of antigrade pulmonary flow. Remember, we saw the one patient who just had regurgitant flow through the pulmonary valve. And this usually indicates that the right ventricle and tricuspid valve are just not able to generate pressure, either because of severe tricuspid insufficiency or because the right ventricle is so abnormal that it can't generate enough pressure to open the pulmonary valve. And that tends to have a poor prognosis. This is a paper from 2010 looking at, there were 16 patients overall with Epstein's operated. And obviously the ones who didn't need any intervention were the ones who did best. They're the ones with more mild disease. Ones who just got a shunt were next. These were the ones who had some stenosis usually. And then patients who had a right ventricular exclusion, so-called Starnes operation, to patch over the tricuspid valve and exclude the right ventricle, and then usually plicate the right ventricle to reduce its volume a little bit, did worse. And those in whom they tried to do a valveplasty in the neonatal period really did badly. So this, it turned out, was not a very good option for these patients. And if you look, this is another paper a little bit later, looking at Epstein's overall. The mortality, in-hospital mortality for neonatal Epstein's was almost a quarter of the patients. So this is still not a solved problem by any means. And then you can see the mortality later on, of course, is quite low, as we would expect. And the last thing I'll just talk about briefly, this is something that you just never see. There, I don't have an example in the registry. Is so-called Ewell's anomaly or Parchment right ventricle. There's very little to no right ventricular myocardium present. It's mostly just fibrous tissue in the right ventricular wall. This seems to be a developmental abnormality because it presents right away in neonates with heart failure. It's not right ventricular cardiomyopathy or arrhythmogenic right ventricular cardiomyopathy. It's very different from that. This presents later in life, is not present in neonates and infants, whereas this typically presents in neonates. And here you can see an example from the literature. As I say, I don't have an example, but this is the right ventricular free wall out here. And you see there's just no myocardium in it. It's all fibrous tissue. Here you can see there's some endocardial fibrosis and just a layer of fibrous tissue here, and some fat on the outside, no myocardium. This is myocardium in the septum. The treatment for Ewell's anomaly in very symptomatic patients is transplant. There's really not much else to do for this. There have been very few cases reported. It's basically like a Fontan circulation, naturally occurring. And just to contrast it with right ventricular cardiomyopathy, this is, we'll talk about this when we talk about cardiomyopathy later on, but it's really quite different from what we see here. So at that, let's, unless anybody has any questions, let's stop. And
is the LV myocardium totally normal in Ewell's anomaly?
in Ewell's, yes, I believe it is. You know, again, this is not something that we see very often. But yes, it should be normal in Ewell's. So we'll look at some specimens now, I hope. Let me just see if I can get this to come up. So we'll look at some specimens now of right ventricular abnormalities, and we'll start with double chamber right ventricle. So here we're looking in the right atrium and right ventricle in this heart. You can see there's superior vena cava. Here's the fossa here. And this is a big coronary sinus. Tricuspid valve is here. So this is the inflow portion of the right ventricle. But we don't see anything leading up to an outflow. There is a ventricular septal defect here, a membranous type of defect here at the commissure between the superior anterior leaflet and the septal leaflet. And here is a little opening here that takes us up into the infundibulum. Here's pulmonary valve. There's some fibrous tissue here, and this is the junction between this outflow or infundibulum and the sinus or inflow portion. So this is what's been called the proximal os infundibuli, the mouth into the infundibulum, and that's what is stenotic in patients with double chamber right ventricle. And this seems to be due to a couple of mechanisms. One is basal displacement of the moderator band, and the other is elongation, excessive length here of the infundibular septum or outlet septum, the muscle bundle under the pulmonary valve. So those seem to be the two major players that contribute to this, and the surgeon can come in and resect muscle here to create an opening between the inflow and outflow portions of the right ventricle. Here is another example. This is a larger heart. And so here again is our right atrium, right ventricle. And you can see in this case, here's the moderator band. You can see how displaced it is basally. And here's the opening between the right ventricle and the infundibulum or outflow up here. So here's our outflow pulmonary valve, nice normal looking pulmonary valve here. And there's the moderator band, again displaced basally in this case, causing some narrowing here. This was mild double chamber, but nonetheless it is a double chamber right ventricle with the stenosis here of the proximal os. You can see there's some fibrous tissue buildup around it here, probably because of increased flow velocity in the area, and then a relatively normal pulmonary valve up here. This patient had a ventricular septal defect here, through which the aortic valve had prolapsed, and then he acutely developed a tear in the leaflet of the valve and developed severe aortic insufficiency. So that's another example of double chamber. And the last one I'll show you is a very tiny little heart. So here's again our right ventricle, right ventricular inflow. There's a ventricular septal defect there going over into the other side. But here, if we look here, here's the infundibulum or outflow. There's a small pulmonary valve in this case right up here, very stenotic. And this is the junction between the inflow and outflow. So this is, again, an extreme case of double chamber. This probably is moderator band here. And then this is all infundibular septum here that's, again, elongated, hypertrophied, causing severe double chamber. This patient obviously died soon after birth. And there you can see through the ventricular septal defect into the left ventricle. Over here on this side there again is this large ventricular septal defect right here. So this is a severe double chamber right ventricle. So those are some examples of double chamber. Another abnormality that we see in the right ventricle is right ventricular hypoplasia. There are some examples of this here. It's usually associated with tricuspid valve hypoplasia. So here's the opened right atrium, and this is the orifice of the tricuspid valve, which is really quite small in this case. Here's the mitral valve on the other side for comparison, and you can see this is really quite a tiny tricuspid valve orifice here out of this right atrium. And if we look in the right ventricle, it's quite small. Just looking from outside the heart, you can see that the anterior descending artery is all the way here. Normally, the anterior descending would be over and about this location, whereas the anterior descendings move this way because the right ventricle is very short in an apex to base dimension. It doesn't go anywhere near the apex in this heart. This is really all there is to it right here. Is this little part of the right ventricle. You can see the tricuspid valve coming into it there. It's quite small. And the pulmonary valve is up here, right here. It's a bicuspid pulmonary valve, but good size branch pulmonary arteries, probably because there was a ductus arteriosus. And then this patient had a shunt created because the right heart was insufficient to supply pulmonary blood flow. So here's a modified Blalock-Taussig shunt from the innominate artery here down to the right pulmonary artery, typical modified Blalock-Taussig shunt. The left ventricle is hypertrophied on the other side. There's more cavity here. There's the anterior mitral leaflet, but this right ventricle is quite small. The other time that we see right ventricular hypoplasia like this is in patients who have pulmonary atresia with intact interventricular septum. And this is an example of that. Here's the left ventricle on this side. If we look over here on the right, here's our right ventricle. And you can see there's a big papillary muscle here. Most of the tricuspid valve leaflets come down to that. You can see this kind of parachute. But here's the dimension of this right ventricle. There's some trabecular right ventricle out here toward the apex. This is a rather common finding where you get this constriction sort of where the moderator band is, and then some more right ventricle, but muscle-filled cavity out here toward the apex. And that's basically what we have in this patient who had pulmonary atresia intact septum and had the pulmonary valve basically resected here in the right ventricular outflow tract opened. So this is another time when we can see hypoplasia of the right ventricle. That's probably one of the more common ones. Now, another example of right ventricular hypoplasia occurs in patients with transposition of the great arteries and left-sided juxtaposition of the atrial appendages. Here you can see the right atrial appendage and the left atrial appendage juxtaposed to the left side. Here's our aorta, anterior and to the right, pulmonary artery here, posterior and to the left. typical of detransposition. And if we look in this right ventricle, you can see that it's hypertrophied. And again, notice here's the anterior descending. It isn't out here where it usually is. It's a little further anterior and rightward because this right ventricle doesn't quite make it to the apex of the heart. Again, it's a little bit small. And look at the size of the tricuspid valve here. It's pretty small. If we compare that with this mitral valve on the other side, you can see that the tricuspid is maybe half or 2/3 the size of the mitral valve. Typically, the tricuspid valve is 20–25% bigger than the mitral valve. So this is tricuspid valve hypoplasia, right ventricular hypoplasia in the setting of transposition of the great arteries. Patients like this usually can have an arterial switch operation, but they often have pleural drainage, pericardial drainage postoperatively, much like patients with a Fontan operation. So when you see juxtaposed appendages like this, be concerned about the size of the tricuspid valve and right ventricle. They're often small. So those are some examples of some of the abnormalities that we see in the right ventricle, double chamber right ventricle, and then right ventricular hypoplasia. Another abnormality that we see is Epstein anomaly of the tricuspid valve. And this is an example of a neonatal Epstein anomaly. This is right atrium here. This is the tricuspid annulus. That's where the valve should be, but of course it isn't. This is all atrialized ventricle, very thin-walled ventricle down here, very dysplastic looking ventricle. And this is what there is of tricuspid valve tissue. Here's the septal leaflet. There's a little bit of anterior leaflet up here, and that's really all there was. And it's opening up into the infundibulum. And here's the pulmonary valve up here, not a bad sized pulmonary valve, considering here are the branch pulmonary arteries up here. But this tricuspid valve is very dysplastic. Here's the anterior leaflet here, here's the septal leaflet. So you can imagine that this patient had just tremendous tricuspid regurgitation and died in the neonatal period. You can also imagine how this markedly dilated right atrium and right ventricle would take up a good bit of the baby's chest and can interfere with lung development. It can also interfere with left ventricular filling back here simply by taking up space in the pericardium. And so you can have low cardiac output in neonates, which is how many of these babies present. And this patient had a large interatrial communication. You can see here, here's the primary atrial septum, septum secundum up here, so had a very large interatrial communication. But marked dysplasia of this Epstein's tricuspid valve, marked dysplasia of the right ventricular myocardium over here, marked thinning, probably was unable to generate a lot of pressure in this very dysplastic ventricle. So this is an extreme form of neonatal Epstein's anomaly. Here is another Epstein heart. This one is, well, it's not really Epstein because there's really no tricuspid valve here at all. This is what's been called unguarded tricuspid orifice. So here's our right atrium over here on this side. You can see this is where the tricuspid annulus should be, right here, this little ridge right there. And so then this is right ventricle on this side. And there's pulmonary valve atresia. Here's the little pulmonary root with the atretic pulmonary valve. You can see a little raphe there. Some sinuses have developed here. There's another raphe over here. So this is, and if we look on the inside, we don't see much of anything. Just that little dimple right there is where the pulmonary valve would have been, but there's pulmonary atresia in this case. So this was just blood sloshing back and forth from right ventricle to right atrium with no antigrade flow. And there is an atrial communication. You can see the cribriform primary atrial septum right there on in the fossa. So this is an unguarded tricuspid orifice. I sort of think of this a little bit like Epstein's anomaly, even though it really isn't, because there's no tricuspid valve here to be displaced down into the ventricle. But this is another abnormality of the right ventricle associated with tricuspid valve problems. Now we can look at some other examples of Epstein's anomaly. Here's an opened right atrium and right ventricle in this heart. Here you can see this is the right atrium back here, coronary sinus here. This is the valve annulus, where the valve annulus should be right here. And here you can see this is the anterior superior leaflet. It's a big sail-like leaflet, which we often see in Epstein's anomaly. It doesn't have much opening in it. The cords are all fused and matted here. And then here's the septal leaflet right here. And the opening of this valve, instead of being toward the apex of the ventricle in this direction, is really up toward the infundibulum. So this rotation is part of Epstein anomaly as much as displacement of the leaflets. And here you can see this is all atrialized ventricle down here. The plane of opening of the tricuspid valve is up here. So this is ventricle myocardium, but it's exposed to atrial pressure. So here's again, the sail-like anterior leaflet, and then this is the displaced septal leaflet. You can see these sort of almost gelatinous-like looking little leaflets here. Instead of the valve pointing this way toward the apex of the heart, it's rotated anti-clockwise about 90 degrees so that it points up toward the outflow. And if we look, here's the opening of this valve up toward us here. Here's this big, again, sail anterior leaflet. And this is the displaced septal leaflet over there. And here's our pulmonary valve up here. So this is all infundibulum. So the functional part of this ventricle is this, that's on the ventricular side or the downstream side of the closure plane of the tricuspid valve, which is about here. And so this is functional ventricle, and the part below down here is atrialized ventricle. This is on the atrial side of the closure plane of the tricuspid valve. So this is a patient who would have had severe tricuspid insufficiency, and that's why the right atrium and this atrialized part of the ventricle are so dilated. And then there would have been, this patient did have antigrade flow, of course, out to the pulmonary valve, which looks relatively normal in this case. But there would have been a lot of tricuspid insufficiency. I think we'll stop at this point and see if anybody has any questions about anything.
I just had a quick question, just because we're on
Sure.
the topic of ventricular changes, although I don't know if you're planning to address this in a different talk. Do you see gross changes that are visible on this kind of investigation with ARVC?
Oh, yes, you definitely do. And we will talk about that when we talk about cardiomyopathy. But yes, what you see, of course, is loss of myocardium, patchy loss of myocardium, usually full thickness loss. And you see, tongues of fibrofatty replacement going through the myocardium. So you see thinning and then actual replacement of myocardium, patchy replacement. So yeah, on a gross level, yes, you can definitely see it.
Thanks.
Mm-hmm. Other questions? Okay, guys. So that'll be it for today. and we'll